I think we'll take the questions at the end. The next topic is presented by Dr. Dilip Kumar. Sir is a phaco surgeon at Sanatana Eye Care, Chavakal.
Thank you, Dr. Sunitha. Good afternoon. The ability to perform a cataract surgery, whether it is a phacoemulsification or nowadays even small incision cataract surgery under topical anesthesia, is a milestone to be achieved in our career as a cataract surgeon. Why to go for a topical anesthesia? What exactly is the advantage for the patient? The main factor keeping most of the patients away from undergoing cataract surgery is the fear of pain of injection. That is totally eliminated when we do the surgery under topical anesthesia. And we know in peribulbar anesthesia, when we give the injection, the patient may have to wait in the preoperative room for 5 to 10 minutes while we are doing the eye massage or by keeping the weight in the eyeball. But that is not required in a topical anesthesia. Then quicker postoperative visual recovery, and it is also better cosmetically. Because in a peribulbar anesthesia, we know there are chances of ptosis or periorbital ecchymosis, subconjunctival hemorrhage and all. That is not there in topical anesthesia. And even grievous complications like orbital bleeding or globe perforation and optic nerve injury all will be absent in a topical anesthesia. And why it is good for the surgeon? In a peribulbar injection, we know there are chances of sudden rise in the intraocular pressure once the injection is given. And in some other cases, when we give the injection and we overdo the eye massaging, the eye may go for a hypotone. That is not there in topical anesthesia. In topical anesthesia, the surgeon gets to operate in a normally pressurized eye. And the patient can maintain the coaxiality of the eye, which will help us to perform the surgery more better. And usually we will avoid using any sharp instruments while doing the surgery under topical anesthesia, which help us to make our tissue handling more delicate. The surgeries will become faster, and it's also essential to improve the practice as a cataract surgeon. And before moving on to topical anesthesia, the surgeon should be confident in his surgical skills and he should be getting consistent surgical outcomes. Patient selection is very important when we start doing cases under topical anesthesia. You have to select a very cooperative patient. You can observe how the patient behaves when he comes to the OP while we are doing a slit lamp examination or a dilated fundus examination with 90D or while doing the applanation tonometry. All this will give us an idea how the patient will cooperate in the theater. If the patient keep on squeezing or blinking his eyes while we are doing these procedures, commonly termed as office blinkers, better to avoid such type of cases in the learning phase. You have to select a patient with clear cornea, well dilated pupil, and it will be better if the nuclear sclerosis is of grade 2 to 3. Once you are confident in that grade, then you can slowly move on to hard cataract and soft cataracts. You should never tell the patient that there will be no pain. Patient can always feel the sense of touch, pressure, and temperature. During certain stages of the procedure, like in phaco, like while we are making the incision, or while going inside the eye with the phaco probe in a continuous irrigation mode, or while doing the irrigation aspiration, or while IOL implantation and all, patient will surely feel a sense of pressure, like we are pressing the eyeball with a finger. It is due to the ciliary body stretch. During all these procedure, you just warn the patient and ask them to keep both the eyes relaxed, wide open, and keep on focusing at the light from the microscope. There are certain cases where it is better to avoid topical anesthesia. That is extremes of ages where the cooperation will be not that good. Then patients with hard of hearing, nystagmus, those with a poor past experience with topical anesthesia in the other eye. Then patients with iris issues like poorly dilating pupil or a synechia where you may have to go for a pupil expanding device, or in subluxated cataract where CTR may be required. All these cases it is better to go for a subtenons or a peribulbar injection. These are few medicines which are used for topical anesthesia. Proparacaine is the most commonly used medicine. It gives a duration of action of nearly 15 to 20 minutes. Then tetracaine 0.5 to 1% is also there. It also gives same 15 to 20 minutes of duration of action. Lidocaine gel 2% is there. It will give a little more duration of action up to 20 to 30 minutes. I'll show a small video, relevant steps where you have to be careful while doing the surgery under topical anesthesia. Fixation of eyeball should be gentle but firm. You can always use a cotton bud for the fixation. Other options include you can use a side port incision, second instrument through a side port incision, or there is something called Thornton ring. My incisions are usually temporal, so I will keep a bud on the nasal side, which will give a counter traction while making the incision. Then, while injecting the visco, you should be careful not to overfill the anterior chamber with the visco because too much deepening of the AC may again cause ciliary body stretch, which can elicit pain for the patient. And then coming to rexis, if you can train yourself to make the rexis without the support of a second instrument, that will be more helpful. And then finishing the AC, the rexis, then while making the side port also, we can use a cotton bud. Now coming to hydro, the hydro should be complete. If you try to rotate the nucleus with an improper hydro, it can induce pain. That is because of the sonular attachment onto the ciliary body. So the hydro should be complete, and you should make sure that the nucleus rotate properly before starting phacoemulsification. And when you go inside the eye with the phaco probe, it is always better to start with a low bottle height, say 80 centimeters. And once the intraocular pressure is equilibrated, then you can slowly reset the height of the bottle. The mechanism of the method of nucleus disassembling, you can either do a divide and conquer or a stop and chop or a direct chop. That is not really significant. And it's always better to moist the cornea with visco than keep on putting BSS. Because if you keep on putting BSS, that may elicit skewing. And from the time you can use a second instrument to fix the eyeball movement will be mostly under surgeon's control. And once the last piece is done, then you can go for a cortex wash. I usually use a bimanual irrigation aspiration technique, which again gives me a control over the eyeball movement. And then once the cortex wash is done, I usually do a visco fluid exchange. This is to prevent the sudden shallowing of the anterior chamber. And once the visco is done, then we can go for the IOL implantation. I slightly extend the inner lip of the sulca incision before implanting the IOL. This will help us to reduce the stretching of the incision or corneal nerves, which can induce pain for the patient while implanting the IOL. And you can put the IOL. These are the few steps where you have to be careful while doing the steps under topical anesthesia. And throughout the whole procedure, you should be very careful never to touch the iris or engage the iris with the phaco probe or the irrigation aspiration probe. Doing surgeries under topical anesthesia is only a mental block, the same block which we had when we started the phaco, or when we moved on from divide and conquer to stop and chop or phaco chop. You can always practice selective steps with a seasoned surgeon with whom you are working with. And there are a lot of excellent videos in the net. You can keep on watching those videos and polish your techniques. Thank you.